You are kind of the first in this series that we're doing. We're just going to kind of try to talk to all the different residency directors and get what is like unique about each program, or why what might entice different types of people to apply to different programs. So I just have some kind of questions to go through with you, and then if you have anything that you want to let us know about the program at Baylor and TWU, we can definitely go into that as well. Sound good?
Sounds good.
So let's just start with kind of the logistics about your program, just like when in the year does it start, how long it is, when applications are typically due, that kind of stuff.
Sure. So we usually have applications ready in October. As of right now, we are not doing the PTRF CAS, so the online system. We're doing our own application, and part of that's because we, get enough applications that we can handle fairly well on our own, and don't feel like we need to go through a central scheduling or central application system. So we have them ready in October. So I'll send out applications in October to anybody that's interested that I already have, and people can continue to inquire at that point. But they are due January 15th every year. So we have to have everything in for the application, and the application is fairly simple. It is just a one-page demographic, and then we need 2 letters of reference. If the person is going to be a new grad, one of those references has to come from a professor at the university, and then one of them needs to be something clinical, so a CI or somebody where they volunteered or something like that. And then also they have to write a 1 to 2 page essay about why they are interested in women's health, but then also why specifically a residency. There's a lot of different ways that you can get into women's health, or you can continue post-professionally. So what specifically about our residency speaks to them? And so then January 15th, we close applications, and we interview typically late February or early March, depending on when CSM is that year. And we take 2 residents every year. And we do that because we have 2 clinical sites for our residents, and they spend 6 months at each site. And so the residency program starts usually the first Saturday in June, and they are going through a 10-day intensive lymphedema program at that point. And then they have about 4 days off, and then they go through Baylor orientation, and then they start in the clinic. And our program, because we don't expect people to have this big breadth of women's health knowledge, they come in and it's kind of a ramped up mentoring program really at the beginning. If you do an orthopedics residency or you do a neuro residency, you've had semesters of class and you come in with a base knowledge. With women's health, we have to provide you with that base. And so at the beginning of the residency program, you are starting with kind of more what we would consider the orthopedic type of women's health patients, so scoliosis, female athlete, SI joint dysfunction, fibromyalgia, those kind of chronic pain, those sorts of things. And you very early on are starting with maybe a 10-hour caseload, and then you're doing some of the other hospital requirement stuff, and then you're spending time in the room with us, with our patients, and kind of learning some things. So really you're not getting your full resident caseload until about 6 weeks into the program. And that's because you have to be going to coursework at TWU, and you have to really get some foundation first. So one will be at one clinic for 6 months, and then one will be at the other, and they flip at the new year. So the coursework is partnered with Texas Women's University here in Dallas. And they, after the lymphedema course, they kind of start in the clinic. So now we're at the end of June. And then there's 2 weekends in July that they do a female anatomy class, and that's a cadaver-based course. It's 100% in the classroom, and there's dissection portion with the cadaver, and that's taught by myself and an anatomist. And so they kind of get more in depth than what you learned in your general anatomy class, and kind of put the whole picture together. So how does the diaphragm work with the pelvic floor? And then in the fall, there's 2 courses, basic lifespan women's health, and then women's health special topics, so pelvic floor and OB. And then in the spring, there is another advanced special topics in women's health. So that's when we go through high-risk pregnancy, male pelvic pain, advanced colorectal. And there's lab portions to all of those classes, with the exception of the lifespans course.
Okay.
I think I got all your questions in that.
Yeah, perfect. So
the residency ends at the following June, at the end of June.
Okay, so it's 12 months long.
Yeah, it's 55 weeks. So they overlap a couple weeks while the prior residents are finishing up in the clinic and the new residents are starting lymphedema. So they actually spend about a week in the clinic together.
Okay, great. So with all of that coursework that you kind of have in the first 6 weeks, do you guys require the residents to come in with any pelvic floor 1 or OB courses?
We do not require. We cover all of that at the Texas Women's courses, but we also, the first 6 weeks, every Friday is a skills lab. And so we are doing formal instruction at that point as well and doing skills checkoffs. It's obviously highly advantageous if they have had some exposure and if they have taken the coursework, particularly the internal pelvic floor. It's a little bit easier to teach the pregnancy just because it's ortho-based, but the internal pelvic floor is always helpful. But we've taken residents that have not had it and they've excelled perfectly fine, so we do not require that.
Okay. Does the residency include a research component?
The research component that is included is a case study, and that is kind of their capstone project at the end of the year. They have to present at a continuing ed opportunity. So we apply to the TPTA, and along with their classmates, they present a case study. We do have research going on at Baylor in pelvic floor, chronic pain, and so they do have the opportunity to participate in that, but it's not required. A couple of residents have chosen to participate in it, and a couple have chosen not to because they've felt like they had enough on their plate, so that's an option.
Okay. And how about like opportunities to grow or move into teaching or leadership positions, like with the residency after you finish? Is there room for that? Or do residents typically kind of move on and do their own thing after they finish?
So you mean within Baylor or?
Yeah, within, like, is the residency currently growing and expanding and looking for more leadership, or is there opportunity for the residents to kind of develop into a mentor for future residents?
Sure. So currently right now, we are not looking at taking any more residents. So we're trying to keep it at 2. However, every resident that has wanted to stay with Baylor, our program itself is growing. And so we have absolutely been able to hire everybody that's wanted to stay. And there has been opportunity for them to become mentors. So as our program has grown, we have had past residents become mentors within women's health, and we are now starting an oncology resident. And so actually one of our former residents has found a love for oncology, and so she is actually going to be involved in the oncology residency. So there's awesome. A lot of room to grow. We also, because you're taking Texas Women's courses, these courses can apply to other postgraduate coursework. So we had several that ended up doing a transitional doctorate, but people that have come in with the doctorate, we've had 2 go on to do their PhD. So they're in that program right now, and one is almost finished with their PhD. And so she will go on to teach outside of Baylor, but teach. So we've been able to definitely offer those options.
Awesome. That's awesome. So you did kind of mention the mentoring in the beginning, that typically there's a whole lot of that in the first 6 weeks. How is that structured kind of throughout the rest of the program with those one-on-one mentoring hours?
Yeah, so once the first 6 to 8 weeks is done, we never do less than 2 hours a week. But in the middle of the program, you're typically going to get 4 hours with various mentors. We have at least 2 at each site. One site has 3. And depending on what your needs are, we'll determine which mentor you're going to spend the majority of time with, because we all have our specialties. And we've never done less than 2, because even in the end of the residency, we're mentoring you on different things. And so even though, yeah, you're at the end and you might be, having learned all the basics, there's still always room for mentoring. I've been doing this 17 years and I still go to my mentor. So you're just mentoring on different topics now. And so just because you're at the end of the residency doesn't mean you don't get mentoring anymore. But it's definitely front loaded, but we're front loading on the knowledge piece. And then at the end, we're really working on clinical reasoning skills and taking it to a higher level.
Okay, great. What would you say is, and you may have touched on this already with some of your explanation, but what would you say is unique to the program at Baylor versus some of the other residencies?
I definitely think one of our, I don't know how unique it is, but I think our positive is our clinics are in larger outpatient orthopedic clinics. And so women's health is not just isolated by itself. And because of that, we have a really highly collaborative environment. So the one clinic, the entire floor is outpatient. And so that's orthopedic, speech, OT, and neuro outpatient. And so the neuro resident is on that same floor. And the two residents actually share a lot of patients because we do a fair amount of neurogenic bladder. So patients with MS, Cauda-Equina syndrome, Parkinson's. And so the neuro resident is often treating the balance and the functional kind of walking deficits and that sort of thing. And then the women's health resident is working with their mentor to treat the bowel and bladder dysfunction that goes along with those diagnoses. And so it's a great co-treating environment and probably seeing a lot of caseload that they wouldn't if they weren't in this large hospital setting. Plus, because you are in an orthopedic clinic with your orthopedic colleagues, in the 8 years I've been there, I've just seen an explosion with orthopedic colleagues being able to identify what is going on potentially with their patients with back pain and their patients with hip pain, and the fact that the hip pain might actually have a pelvic floor component and that the obturator internus in the pelvic floor might be causing some of the hip pain, and being able to pull the resident in to maybe do a screen. And so there's a lot of coordination and co-treatment going on. And I think that's a really great learning environment. We also have 3 accredited residencies. Sports is about to have their site visit, and acute care is starting as well. And then I mentioned oncology will be up and running in a couple years. So there's a lot of room that our residents are collaborating with each other. So there are specific times during the year where all programs are together. So an example would be like female athlete is in all DSPs for sports, ortho, and women's health. So what we do is have the sports, ortho, and women's health residents all get together, and they bring their piece and kind of their lens on how they look at the female athletes. So sports will present on prevention and on-field injuries with female athletes, and ortho will present on landing mechanics and some of the rehab issues. And then women's health will present on the pelvic floor components and the issues with urinary incontinence and anal incontinence in endurance runners and gymnasts. And so all the residents get to learn from each other and be able to see that same topic through each specialty lens. And so I think that's really exciting and a great piece that we can offer.
That's awesome. That sounds like a really great environment to learn in. Kind of finishing up, I guess, is there, wondering kind of what your ideal applicant or candidate to the program looks like, and any advice that you would have to the students who are interested in applying to your program?
I get asked that question all the time, and it's such a horrible question to answer because it's hard to answer because every year looks different. We have taken new grads that have had very little experience, and we have had people that have had 15 years of physical therapy experience with no women's health experience. So it's really hard. I think our program truly is eclectic in the ones that we take, but what everybody has in common is they're really passionate about women's health. They are really active learners. So what I mean by that is they don't wait to be spoon-fed, that they can take a direction and I can say, okay, we're going to talk about this topic tomorrow. And they can understand and go and look up articles and come prepared and not just expect to be kind of spoon-fed all the information, that they're active learners, that when they are given a task, they can come to me with questions after they've already attempted to find some answers. And that also that passion is what's going to drive them forward to be able to really decide what area they want to go into. Because even within women's health, there's so many specialty areas. And that's what I think I like about our program too, is we have structure, but we have enough flexibility that if you find an area that you're passionate, we can build those experiences in for you. Some of the residency programs are super structured and they have every minute of your year worked out for you. Some are super flexible and you kind of have to build the program. Ours is a little bit middle of the road, and we are going to expose you to a lot of different opportunities. And if you find something you love, we can absolutely help you build that. And we need you to have a little bit of that independence, because we're also not going to be able to spoon feed you everything. Right. So that's probably the biggest, just that active learner who can take a little bit of drive, because what you put into it is what you're going to get out of it. And you can do the bare minimum, but you're not going to have a great learning experience. But when you really do that drive, residencies are tough. They're not a 40-hour-a-week job. It is going to school and working 40 hours a week, and that's tough. And you know, the mentors at our program did it. We all went through and did our clinical doctorate after you know, our master's degrees, and so we worked full time and went and did the transitional DPT. So we've been there, but you know, we understand. But it's tough. But it's a finite period of time, and it's definitely worth it, I think.
Awesome. Well, thank you so much for taking time to talk with me about it. I know all of the students that will check this out will really appreciate it. And I look forward to seeing you around in the future.
Absolutely. Thanks for having me.
Yeah, bye.
Bye.